Welcome back to Corium. I'm Brian Gilberti, and today we're joined by Dr. Ellen Duncan, who is Assistant Professor of Pediatric Emergency Medicine and the Program Director of the Pediatric Emergency Medicine Fellowship Program here at NYU. So naturally, she is our specialist in all things related to kids. Great to have you back, Ellen.
Thanks for having me back. It's always great to be here.
So today we're going to talk about ataxia in children, which is a presentation on the pediatric side that can have etiologies that range from self-limiting to life-threatening. So I'm glad that you're here with us to break down the general approach. And let's start off with a case here. And this time it's okay to use patient identifiers.
Yeah, so we talk about a lot of interesting cases from work, but this case actually involves my younger son, who was 18 months old at the time.
Okay, and tell us more. Tell us what happened.
So for background, he's a full-term vaccinated kiddo. His only medical history is recurrent otitis media and reactive airway. Like most kids in daycare, he's had back-to-back respiratory infections for most of the fall, but was otherwise well. One morning at the end of November, I went to get him from his crib, and as soon as I got him out, I noticed that something was wrong. I picked him up, and his head just fell backward like a rag doll.
Wow, so this is going to be unnerving for any parent, even a PEM doc. So tell us what happened next.
So I tried to put him down on the floor, but he couldn't even sit. He just kept falling to the side. When he started vomiting, I knew it was time to take him to the ED.
And Ellen, so just to be clear, the evening prior, he was totally well. Normal posture, walking and talking like he normally does, I assume, right?
So, there was a moment before he went to bed where he stumbled backwards a little bit, but it didn't really seem unusual. He had started walking at 17 months, and he was still perfecting it. But other than that, he was his usual active, happy self.
Okay, so at this point, you've decided to take him to the ED, which I bet isn't an easy decision for any parent, especially a PEM doc.
Yeah, it's definitely something I think many of us struggle with. We don't want to rush to the ED, but we also don't want to delay if there's something potentially serious going on. At this point, though, I knew I had to take my medical hat off and just be mom.
Of course. And tell us what happened next when you got to the emergency department.
So the ED team did a full neuro exam, which was really only notable for ataxia in the form of difficulty with his balance. He was still falling to the side when trying to sit and stand. He had normal strength and was moving his arms and legs equally. He was happily pointing out all the different trucks in his book while he was sitting on my lap. The only other notable finding was that he had thick fluid behind both of his TMs.
Okay, so now let's take a step back. Let's talk about what is on the differential at this point. We have an 18-month-old boy with acute onset difficulty sitting and walking. What should be going through our head at this point?
So the most common cause of ataxia in our pediatric population is going to be acute cerebellar ataxia. But some other things to think about include drug ingestion, Guillain-Barre syndrome, and basilar migraine. There are several less common conditions that can lead to ataxia as well, including cerebellitis, encephalitis, brain tumor, and labyrinthitis. And that's not even the full list.
And these are certainly concerning processes on the list, with a diagnostic approach for each one that's going to be varying considerably, right? So how are we going to be using our history to whittle down the differential and direct the next steps in our evaluation?
So in any patient with ataxia, it's crucial to get a clear time course. The most common presentation we'll see in the ED is acute ataxia, which is generally characterized by symptoms for less than a week. You should also ask about any prior episodes or family history of similar symptoms, any recent or current illnesses, history of trauma, signs of increased intracranial pressure, ear pain or recent infections, and any possible toxic exposures.
Yeah, and going back to your son, we've checked a couple of these boxes, right? Recent infection, recurrent otitis media, and possible signs of increased intracranial pressure with vomiting. Okay, so we've completed gathering our history. Let's move on to the exam. What are you looking for?
So look closely at your vital signs for bradycardia or hypertension that might indicate increased ICP. You can also tell a lot about patients from afar, especially kiddos who might not want to cooperate with your exam. Pay attention to the child's overall appearance, as well as their fine and gross motor skills, head positioning, truncal stability, gait if you can observe it, and attention. Overall appearance is so important. Patients with cerebellitis and encephalitis will look ill, whereas patients with cerebellar ataxia will generally look well. Those with drug ingestion often have a pretty significant discordance between their neurologic symptoms and their overall well appearance. Vomiting should put things like cerebellitis, labyrinthitis, and increased ICP higher on your differential. And in addition to your standard physical and neuro exam, you should also pay close attention to the presence of things like meningismus, bulging fontanelles in infants, and signs of otitis media, rash, or trauma.
Okay, and that's exam, a very important part of this. Tell us about blood work and the role of neuroimaging.
So it's always a good idea to get a point of care glucose in a patient who doesn't look quite right. If you're concerned about things like trauma, altered mental status, increased ICP, or stroke, you should get whatever head imaging is most readily available, which is usually a non-con head CT, but can also be a fast MRI if that's available to you. Remember that MRI is better for detecting abnormalities in the posterior fossa. Anyone with signs of meningismus should have an LP, but only once they're stable enough to do so.
Great. And now at this point, we can start talking about treatment for these patients.
Yeah, so treatment really depends on the underlying etiology. Acute cerebellar ataxia is self-limited and usually resolves within a few weeks, but it can occasionally persist for months. Antimicrobials should be started whenever there's concern for meningitis or encephalitis, and steroids can be useful in patients with cerebellitis and acute disseminated encephalomyelitis, or ADEM. Be sure to reach out to the appropriate subspecialty services like neurosurgery for patients with things like intracranial masses and hemorrhage.
Perfect, Ellen. Okay, now it's time to go back to the case. Tell us about what happened to your son.
So ultimately, he had a normal fast T2 MRI and actually started getting better throughout the course of his ED stay. The team thought that he had some combination of cerebellar ataxia, likely from one of his recent viruses, and labyrinthitis from his recurrent otitis media. A couple of weeks later, he actually got myringotomy tubes placed, and he has not had any more acute neurologic changes or episodes of otitis media since then.
Perfect. Now, before we end the episode, let's go over some take-home points. Ataxia in children can have a wide range of causes, from self-limiting conditions like acute cerebellar ataxia to more serious illnesses such as brain tumors or encephalitis. It is crucial to approach each case with a thorough differential diagnosis. And just as Dr. Duncan did, it is important to recognize and respond to acute symptoms promptly. In any child presenting with ataxia, the diagnosis can be clinched and the direction of the workup can be determined by a detailed history and physical examination, which are going to be essential here. Key aspects to focus on include time course for symptoms, recent infections, signs of increased intracranial pressure, and possible toxic exposures. Also, as is the case with a lot of things in emergency medicine, Gestalt is going to be invaluable here. Initial workup should include point-of-care glucose testing and neuroimaging if there's a concern about trauma or altered mental status or increased intracranial pressure. MRI is preferred for posterior fossa abnormalities, but a non-con head CT is commonly obtained because of its ease of obtaining this kind of study in most emergency departments. Since the list of causes for ataxia in children is extensive, we'll just focus on the treatment for Dr. Duncan's case, which is acute cerebellar ataxia. And this is going to be a self-limiting condition that just requires the tincture of time. Okay, that'll do it for this episode. Ellen, thanks so much for being back in the studio, and we're all glad to hear that your kiddo is back to good health and enjoying his summer.
Thank you so much for having me back.